Hello, everyone, and welcome to today's webinar titled Unintended Consequences of COVID-19, Impact on Harms Caused by Substance Use. My name is Paul Sajan, and I'll be your moderator for this session. I'm the Manager of System Capacity here at the Canadian Institute for Health Information. Before we begin, I have a few housekeeping notes. First, please note that this session is being recorded. For any colleagues of yours unable to attend today, please let them know that the session will be posted to the CIHI website in the coming weeks. Second, we have several polling questions for you. I'm told that you might need to turn off your VPN. In some cases, audience members are not able to see the polling questions with VPN enabled. Third, you'll hear me read each polling question and option aloud. That's because our session offers simultaneous translation, but this applies only to what is said, not what is seen on the screen. And lastly, I will do my best to pose questions from the audience. So if you have a question for our panelists, please type it into the chat box. We have staff behind the scenes monitoring the chat, and we plan to have dedicated time at the end for questions, but please don't feel as though you need to wait. Today, we'll be discussing and interpreting the findings from a recent CIHI study of harms due to substance use during the first 6 months of the COVID-19 pandemic. There are many factors as to why we've seen harms increase during the pandemic, including the use of substances as a means of coping, changes in social support and networks, and the availability and accessibility of support and treatment services. With us today are three panelists to share their insights on this important topic. But before I introduce them, let's ask a few polling questions. May we have the first question on screen, please? I don't see it yet.
So the question is, what is your role in the healthcare system? And choose the most appropriate. Data analyst, policy analyst, policy maker, clinician, or decision maker executive. We're just going to give it a few seconds. Looks like so far the majority of the folks joining are data analysts, followed closely by clinicians. And I'll go ahead and end the poll and then share the results. There we go. Are you able to see it now, Paul? Oh, Paul's screen looks like it's frozen. We're just going to give it a moment for Paul to join. Are you back with us, Paul?
Yes, I'm.
Perfect.
Yes, thank you. Our next two questions look at some of the findings from the report. Now, don't worry, it's not a quiz, but if you haven't read the report, this is a good opportunity to test some of your assumptions. Next question, please. How did emergency department visits for opioid poisoning change between 2019 and 2020, comparing the March to September period in those years? Did ED visits increase by 16%, increase by 29%, increase by 2%, or drop by 5%? I do feel as though we could have the Jeopardy theme song playing, but. Okay, results. So half of our respondents said it increased by 29%, 38% saying increased by 16%. The answer, emergency department visits for opioid poisonings increased by 16%. Poisonings peaked with an 88% increase in September. So thank you. Third question, and final polling question for now. How did emergency department visits for alcohol consumption change between 2019 and 2020, comparing the March to September period in both years? Did ED visits drop by 3%? Was there no change? Did they drop by 11% or increase by 3%? ED visits for alcohol consumption. Over half said increased by 3%, with pretty even 11 to 17% guessing the others. The answer, emergency department visits for alcohol consumption dropped by 11%, but that's not the whole story. Within this decline, visits for non-urgent and less urgent cases dropped more than 20%. At the same time, EDs saw an increase in more severe patients. The number of patients with alcohol-related harms who required hospital admission increased by 10%. So thank you for those who submitted answers, but I think that's enough hearing from me. Let's meet our panelists. First, I'd like to introduce Lisha Di Gioacchino. Lisha is a systems stigma navigator with Community Addictions Peer Support Association, or CAPSA. CAPSA is dedicated to decreasing substance use stigma and advocating for accessible substance use care free of stigma and discrimination. Lisha has conducted research on substance use disorder symptom management and on the prevention of exposure to drugs before birth through her work with the Centre for Addiction and Mental Health, or CAMH, the Canadian Centre on Substance Use and Addiction, or CCSA, the Royal College of Physicians and Surgeons of Canada, and most recently with CAPSA. Welcome, Lisha. Our second panelist is Dr. Matthew Young. Matthew is a senior research and policy analyst at the Canadian Centre on Substance Use and Addiction and an adjunct research professor of psychology at Carleton University in Ottawa. Matthew has been working in the field of substance use and addiction for over 20 years and currently leads CCSA's drug use epidemiology research activities, which includes co-chairing the scientific committee producing estimates on the economic burden of substance use in Canada and leading Canada's Early Warning Sentinel Surveillance Network, the Canadian Community Epidemiology Network on Drug Use, or CENDU. Welcome, Matthew. Our third panelist is Tracy Johnson. Tracy is Director of Health System Analytics here at CIHI. Tracy is responsible and accountable for providing the vision, strategic leadership, and relationships to develop and promote the use of analytic products that address priority health information needs. Welcome to you all, and thank you for joining us. Lisha, I'd like to start with you. Now, you have unique insight to this topic as you bring both professional experience as a researcher and personal experience as a person living with substance use disorder. We've previously spoken, and you've told us that you are willing to share some details of your personal story with us today. If you're comfortable doing so, please tell us more about your experience during the pandemic.
Yes, of course. I'll begin by thanking you for the opportunity to share at today's webinar and by acknowledging the unceded Algonquin and Anishinaabe territory that I'm joining from today. I was invited to join this webinar because I am captured in the data, both as a person who was admitted to hospital for opioid toxicity, as well as an ally, a family member who supported a close loved one who was also hospitalized at the time. And I'd like to touch on all these experiences because we did access multiple episodes of hospital care, because it's a lot more clear the care provided at hospital when you are not the patient. So I can say for myself, I recall waking up and before even knowing if I was going to be okay, I was asked if I was ready to leave. So I don't have an excellent recollection of the entire episode of care that I was provided, but I did also witness, as I mentioned, a loved one accessing care. And we were both managing substance use disorder symptoms well for years, accessing community-based care. And really, COVID had a number of impacts on people with substance use disorder. And I speak from an organization, not just my own living experience with this, but also as a community-based peer organization. So I know these factors ring true for others in Canada with substance use disorder. And that's really that supports were disrupted and changed quite rapidly. So I want to acknowledge that a lot of people delivering substance use care, including emergency physicians, I know we have some healthcare providers joining today. I want to acknowledge and extend my appreciation for how rapidly substance use care providers change the way they deliver care, and that's really excellent. A lot of virtual options. Although specific forms of care were actually disrupted completely. So for me, I was receiving trauma-specific care, so treating co-occurring post-traumatic stress disorder and substance use disorder, and all inpatient group care that's provided at the treatment center. I I access now was disrupted and still is to this day. So when supports are disrupted, that's a challenge. In addition to that, a lot went virtual. So outpatient care went virtual, peer meetings all went virtual here in Ontario. And in and amongst this, of course, there's economic concerns. And within my household, there was changes to employment and a number of determinants of substance use disorder and also recurrence of substance use disorder symptoms. So that led to our symptoms no longer being managed effectively. And I want to mention that I'm thankful for the care provided at hospital. And I recognize that part of the reason we were not, neither of us were provided a care plan to continue care in the community, a release plan, nor a couple other things that I think I'll mention at a later point, is likely because of busyness, the pandemic, and a lack of academic detailing. Although I look forward to later discussing some of the ways that emergency physicians and other hospital care providers could better support people with substance use disorder who were hospitalized during COVID.
Thank you, Lisha. The details of your experience are so impactful, and your journey, I think, highlights that we have two public health crises occurring across Canada, and that in many cases, or in many ways, measures to combat COVID-19 can actually worsen what's happening with the substance use crisis. There's much more that I want to ask you about, Lisha, but I'll turn to Tracy for a moment. Tracy, what was it that prompted CIHI to do this analysis and to look at this issue?
So mental health and substance use is an area that we at CIHI have been involved in for the last 4 years fairly intensively. So through some work with the federal government and provincial and territorial governments, as well as Canadians, we identified a suite of 6 indicators, of which substance use was one of them, through something called shared health priorities. So this was an area where the federal government, the provinces, and Canadians said, we need more data, we need better tracking. Then COVID-19 hit. And when COVID-19 hit, at those federal tables, as well as the provincial discussions we were involved in, we heard that folks were very worried about unintended consequences from COVID more broadly. And substance use, as part of that, became a package of work that we did.
So when you looked at the data, when you looked at what was happening in the first 6 months of 2020, or of the pandemic in 2020, was there anything surprising in the results?
Well, I think that, as Lisha indicated, so we looked at the first 6 months of the pandemic, so April to September 2020, compared to what happened in 2019. And we looked at hospitalizations and emergency department visits for substances such as alcohol, opioids, and cannabis. It's a complex area because what changes patterns with opioids or alcohol can be different. And so depending on the substance, you can see different patterns. What we saw overall, and not necessarily surprising, but it is only 6 months of data, and we will have to continue to monitor so that provinces and territories can understand what services they need to change or provide in a different way, or policies they need to change. But when we look at hospitalizations overall, as you indicated in the survey, hospitalizations increased for harms for all of the substances. We saw a little bit of a different pattern with emergency department visits, and with, as you stated, alcohol drives both hospitalizations and emergency department visits, and a lack of access to alcohol for younger age groups certainly had an impact on those ED visits. Overall, we saw during the pandemic an increase in deaths in hospital as well as in the community. Many more in the community. The ones in hospital are only the tip of the iceberg, but there was about an 82% increase in deaths outside of hospital due to substance use poisoning compared to the year before. So we also saw, interestingly, that among Canadians who use substances, the impact was disproportionately felt by men, as well as people from lower income neighborhoods. So a bit of an overview.
Thank you. And what do you hope decision makers will do with this information?
So we have dual public health crises happening. So we have opioid toxicity crisis, as well as we have a pandemic happening. So what we really do need to be able to do is continue to provide good information on the services that we can monitor right now. We have a dearth of community information in this area. So we use the hospitalization data and the emergency room data as an indicator of what is not available in the community. So should these numbers continue to rise, as Lisha indicated, the services that have been interrupted really need to be looked at with a lens around how that could be changed and or what needs to augment the services that are already out there.
Thank you. Matthew, I'll ask you, what do you think we've learned about the impact the pandemic has had on persons living with substance use disorder?
Yeah, well, I think one of the challenges that we have is that what we're seeing is the convergence of a number of different factors. And I mean, one of the first things that we saw initially, and our Sendu network put out an alert on this, was that we initially saw that the unregulated drug supply, that available in the illegal market, was impacted initially, in fairly unpredictable ways and in different ways across the country. And we've always known, ever since fentanyl entered the drug supply and before, is that when people don't know exactly what they are consuming and how much of that they are consuming, it's very challenging for them to use in a way that minimizes the risks to them and to others who are using the substance. When COVID hit, a lot of the borders were closed, and it really created a big change in the market. Some people were reporting the substances that they rely on were unavailable. Others indicated that they were extra expensive. Others indicated that they were just as expensive, but were very contaminated with sometimes active ingredients and sometimes inactive ingredients. So it caused a bit of chaos within the drug supply. And then you have, in combination with that, you had people being more isolated. And Dr. Gabor Mate oftentimes talks about the opposite of addiction is connection. And so if you have individuals who become disconnected from their supports, from their networks, that makes it harder and more challenging for people who wish or who are trying to remain abstinent. It makes it harder for them to maintain that abstinence, but it also makes it much harder for other people who are actively using, because the other public health information we provide people who use drugs is to don't use alone. While we have contradictory public health messages here, it's important to remain isolated, but at the same time, it's important to not use alone. So we had a whole bunch of different factors that really kind of resulted in the harms that we're seeing now. The last one I'd add is that at least initially in the crisis, we saw a reduction in the availability of both treatment, like Lisha was talking about, but also harm reduction services. So I know that some partners were initially, when supervised consumption sites were trying to adapt, people were trying to schedule appointments for supervised consumption sites. I mean, people who understand this intervention understand that that's not really a viable solution in dealing with in trying to provide supervised consumption activities or interventions. So I think it really was it's a confluence of a whole bunch of different factors that have resulted really in a terrible increase in harms that we see among some of our most marginalized populations.
Thank you for that. I want to ask you too, Matthew, about youth and alcohol, because some of the findings in this report looked at alcohol-related harms as well, and we've seen changes there. Can you tell us a little about what has happened during the pandemic for youth?
Yeah, maybe if I could step back a little bit too. I mean, I think sometimes when we think about substance use, we only think about addiction and people with substance use disorders too. But we also know that there are a lot of people who use substances, and substances can be responsible for other kind of harms, even if addiction or dependency isn't part of the picture. And so what we do see a sudden drop after the pandemic in emergency department visits among youth. And this kind of makes sense because a lot of those visits would be due to injuries or high levels of intoxication associated with overconsumption of alcohol. And so we do see that, and that was really a direct result of the closing down of bars and clubs. And so it does indicate that is an area that's a valuable one to look at if we want to reduce harms among those populations. We also, though, I believe Tracy was talking about how we also see an increase in harms or hospitalizations for people seeking kind of treatment for mental and behavioral disorders due to use of alcohol and other drugs. And so that's an indication that another trend we see in the literature is that at least initially, alcohol consumption has increased among Canadians. It at least initially increased a little bit. It seems to have regressed towards the mean a little bit. It seems to have leveled off, but we do see noticeably individuals who an increase in harms and increase in number of people who have alcohol use disorders seeking help. And then are those numbers, like, and Tracy pointed this out too, are those numbers related to an inability to access community level treatment and therefore arriving at the hospital to get that treatment, which is something, for any kind of policymakers and healthcare systems analysts on the call, one might think that that's a very expensive way to treat people. It's just through the emergency room and through hospitals, where we all know that community level treatment is a much more cost-effective way of working with people who are seeking help with these kinds of challenges.
Thank you. Lisha, I'd appreciate your perspective on this. From your work with CAPSA or from your personal experience, can you tell us more about how people living with substance use disorder are coping during this time?
I mean, it would be difficult for me to speak majoritatively on this, though we always mention that there is still some forms of substance use care available and that it should be accessed. I know members of CAPSA are coping through access to All People, All Pathways, which are peer meetings, and it's a safe place free from stigma and discrimination to discuss relationships with substances. It's open to people seeking to improve their substance use health, as well as allies. And that's one mechanism. It's also quite important there's other forms of peer support as well. It's also important to manage substance use disorder symptoms, whether those be through accessing specialty physician care or substance use treatment programming that does not involve physicians. It's also important to understand some of the additional contributors that are happening during COVID, including increased intimate partner violence, increased stress, and concerns of economic concerns. And so really maintaining a level of, the first portion of substance use care is a stabilization phase. So looking to ensure that we are in healthy, safe relationships and that we're looking to our overall health. One of the things that CAPSA is trying to encourage people to use is the term substance use health. We talk about physical health, we talk about mental health. As Matthew mentioned, it's not just individuals or people with a substance use disorder. Many people use substances and some actually to increase their health. So one of the things that people can do to cope is to discuss their relationship with substances as soon as possible. We don't necessarily need to wait until there's a substance toxicity event or until we are even diagnosed with a substance use disorder. Discussing our relationship with substances is important to do on an ongoing basis.
Thank you. I appreciate that. I think you're starting to flow nicely into talking about how the system can better support persons who use drugs during this pandemic. Matthew or Tracy or back to Lisha, Thoughts on other thoughts on how the system can better support persons at this time?
Maybe I'll continue just because I have my camera on. I think there's a National Specialty Society specific to emergency physicians, CAPE, Canadian Association of Emergency Physicians, and they've released a position statement on emergency management of people with opioid use disorder. I personally think they're fantastic evidence-based guidelines that speak to the importance of emergency physicians and hospital-based care as a critical component of the substance use care system. We know from American data that it's estimated that half of hospitalizations are contributed to by people who have used substances. So we know that hospital-based care is a big part of the substance use care system. Matthew mentioned that it is not necessarily the most cost-effective measure, and I can say from my living experience that it is certainly not the most effective form of substance use care. So I think to answer your question specifically, what we really want to make sure is that substance use is a health condition treated like other health conditions. So I personally don't know of a health condition where if an individual isn't responding to treatment, normally if a person isn't responding to treatment, the treatment has changed, the treatment is increased. Whereas with substance use disorder, often if an individual is not responding to treatment or an individual has, in my case, was no longer able to access treatment, then we have a consequence of my substance use disorder symptoms not being managed and a toxic drug supply, which is why I was hospitalized. It would be very important for the emergency physicians to acknowledge that, find out first of all, and that's part of the guideline is investigating and determining if an individual has opioid use disorder, for the emergency physician to say, okay, this person is clearly not responding to their current treatment. We need to increase treatment, right? The practice point, the position statement rather, also speaks to the importance of providing naloxone and providing opioid toxicity, what word am I looking for? Harm reduction training. So you provide the naloxone and you provide harm reduction training. And this is actually done for the person presenting with the individual hospitalized. So you would actually give naloxone to one or both people. And I think that's very important because when you're releasing people without aftercare or without any sort of care plan, like myself, who have presented because they're using a toxic drug supply and you're not providing them with naloxone, well, it's likely because their substance use disorder symptoms are not being managed in any way that they will continue to use that toxic drug supply. So I had actually asked twice in 2 of these occasions for naloxone, and I was told that by a nurse that they don't have anything like that. So we really need to make sure that hospitals are able to provide naloxone, and also that position statement speaks to the importance of 2 things. One, providing missed doses of Suboxone or methadone, very important, and it gives some logistics around that. And my favorite part is that it speaks to the responsibilization of the emergency physician to ensure that there is a community care plan. So the person is actually released to some form of substance use care. And I think we just have such an amazing opportunity to look at a person who's presented for hospital-based substance use care and say, okay, is this person no longer responding to the substance use care that they're receiving? Does their treatment need to be increased, right? And let's connect someone so they're not being released with no supports. And I can say again from living experience that the substance use care system is incredibly difficult to navigate yourself. I, as a woman, if I'm going to call Ottawa's residential withdrawal management clinic, I will be told 10 days. If I was a man, I would be told 7 days. This is not reasonable when clearly there is a high fatality rate with people in active use, at least for opioid use disorder. And given the drug supply now, it is not, an individual with cocaine use disorder could also be unknowingly taking fentanyl or another opioid. So I hope that answers the question. I'm sorry it was long-winded.
No, that was fantastic. Thank you. Matthew, I've heard you speak in the past about stages of change. Maybe you could talk to us a little bit about that, because I think that ties in nicely to Lisha's comments about harm reduction and drug checking services.
Sure. Yeah. I mean, I think if we, I think there's been a move over the last decade to really start to view substance use disorder as a health condition, and just like any other kind of health condition, there's a progression, and although within addiction, at least, it can be cyclical, and there's a movement back and forth between different kinds of stages of change. And so there, certainly there are some people who are in what we call pre-contemplative stage. So they're just not seeking change right now, and so in many ways we need to meet these people where they're at, and we need to help them. And that's where the harm reduction strategies come in. Another part of the change is what's called the contemplative stage, which is when somebody may actually be seeking treatment, or may be open to seeking treatment, or ready to seek treatment. And for those individuals, we really need to have the capacity to be able to meet them where they're at and provide them what they need when they're looking for it. And like Lisha had said, it really has to be when they're looking for it, because if it's not when they're looking for it, then we're trying to offer it to them when they're not looking for it, and people aren't going to use the services available to them if they transition back to the pre-contemplative stage. And then obviously you also have individuals who are kind of in a maintenance phase. That might be they may be engaging in abstinence or low-level use, but then they might also transition back or relapse. And we need to have proper services in place for people who may relapse, or to help them relapse. Peer support networks that are an ongoing source of support for a lot of people who are in kind of like a maintenance phase, or in that phase. And then we also, I think that really kind of captures it. There are different kinds of services that need to be provided to different people, along their pathway.
And I
Paul,
think, please, Tracy, go ahead.
Paul, I'd say too that we look at this, or at CIHI, a little bit differently, but can add to this picture of, what has some of this information told us? And there's a couple of things that I hear. I hear that education and destigmatization of mental health are really important. Lisha talked about it from the perspective of the statements put out by CAPC. The data that we have shows variation. So while all hospitalizations increased, if you look at the proportion with which they increased, it differs across the provinces. So some provinces were kind of neutral. Others were up to as much as a 23% increase in hospitalizations. That probably speaks to a degree to use patterns and drugs available and substances available in various provinces, but it also probably speaks to program availability. Not only what happened during the pandemic per se, but what happens on a regular basis. So delving down into those numbers is important, and hearing people's stories province to province helps to understand how those programs are effective or not effective. But that variation we see with a lot of indicators, and it is just a first indication that you need to look more closely at what's happening on the ground.
Thank you. Matthew, anything further to add to Tracy's comments before I move on?
No, I think, it's exactly as Tracy had said. I mean, when we look at some of the hospitalization data, it is sometimes tricky to pull out exactly, what it means, because we do know that we at CCSA, we have a group called the National Treatment Indicators Working Group that's trying to kind of calculate, or trying to count or assess how many people are accessing community level treatment. But as anybody who is familiar with this space knows, it's not only is it provincial level, but then there are also private community health clinics, public community health clinics. There are different service providers that provide services and different kinds of services, inpatient services, outpatient services, counseling. So it's a very challenging thing to count and to measure. And when we see the hospitalizations increase, it sometimes is difficult to necessarily tease out, is this due to different levels of provision of service, or is it due to as a kind of a more pure epidemiological indicator that represents harm in the community? It's sometimes it's difficult to do that. I mean, I think we could say with certainty that the numbers that we've seen in the CIHI data are almost certainly partially due to an increase in harm, because we see that reflected in a lot of other data sources too. We see it reflected in the seizure data. You know, we see, because when we see the unregulated drug market has so many contaminants in it. We see it in the death data that's being collected by the Public Health Agency of Canada and the local coroners and medical examiners. So certainly a portion of it is there, but exactly like Tracy pointed out, like when there's variations from province to province, when there are how much of that is accounted for purely by an increase in harms, or by a lockdowns, or a non-investment in those community level treatment services and harm reduction services. That's where it gets very difficult to pull out and to understand what's happening from province to province.
I would also say, Paul, that it's really interesting to listen to CAPC's, and it combines with what Matthew said, listen to CAPC's recommendations around discharge plans. You know, we've been advocating for any other health illness to have a discharge plan when you leave ED, and the connection to community services and follow-up. And it's as important and should be emphasized as much for anyone with an illness of any kind.
So what we're hearing is we don't have enough information about community-based services. We don't know enough about what is happening with this population before they come into hospital. But then also, because of COVID, a lot of those services that we had difficulty tracking dried up or were taken away because of COVID. And it's really made, in many ways, sort of a perfect storm of harm and risk for persons living with substance use disorder. Lisha, is, again, from your work with CAPS and some of your research with other organizations, what other information do you think we need to have to better understand and to better serve populations?
I think it's important to support people as they're willing to access care. Matthew spoke very well about the stages of change. An individual at the point of accessing substance use care may not have abstinence as a set goal. It may become one, but it may not be one at the point of care. So it's very important that all substance use care uses a harm reduction model. All substance use care is seeking to increase substance use health, and that it is never denied. No one is ever discriminated against. Substance use care is never denied to anyone. It's always available, as with other health conditions. And I think we really need to start to acknowledge, it was reiterated earlier that very rarely does a person hospitalized with a disorder not receive an aftercare plan. We need to start wondering, why with substance use disorder are so many services telling people to get better before they can come get care? What do I mean by that? I am not able to go to an inpatient treatment center until I have completed withdrawal management, detox as some may refer to it as. So I'm being denied access to care because I don't know how to get well. So I'm being told I can't get help getting better because I'm not better yet. And then that just leaves more of a responsibilization on the person who is already trying to manage their substance use disorder symptoms and possibly other co-occurring illnesses to then navigate this system, somehow access care right when it is available, So you can kind of see what I'm saying. I think it's very important that we support people in navigating the substance use care system and accessing those services. And I think what would be very helpful if research starts to look at the extent to which people are able to achieve their own substance use health goals. And so often we look at rates of reoccurrence as identified by a urine toxicology sample or a person presenting for hospital-based care, but it would be quite interesting to know how an individual is supported in achieving their own self-identified goals. And I think it would be absolutely wonderful for everything in that practice point to see what data collection indicators are already available in existing data holdings to see the extent to which that position statement is adhered to.
Do we know enough about, for those who do have a hospital stay, do we know enough about their experience in hospital? Do we know enough about the supports that they may or may not have at time of discharge? Can we talk about that at a broad, even pan-Canadian level?
So that's a good question, Paul. At a pan-Canadian level, we do have patient experience. We do have surveys around hospital stays and what patients experience. We can subdivide that data. We've been doing it we've started collecting that for the last couple of years. We can subdivide that data by reason for admission and take a look at whether people got discharge plans with respect to hospitals. So that is one of the things we can do. And we can link that data to folks' previous visits to the hospital as well.
Thank you, Tracy.
Can I add something here, Paul? It's because I think sometimes, like when we talk about something like a pandemic, I mean, it's not a silver lining, but there are some times when things like this that tend to disrupt how we have gone about things in the past can create the conditions where there may be some positive things to emerge. And I think one of the things, like for a long time, we've been investigating different kinds of harm reduction strategies, and certainly, like, you know, one of the strategies that has come quite a long way is drug checking services. So this is a service where people who do use drugs can take a small amount of their drug and provide it to a person, and who will be able to take a look at the contents of the drug and advise the individual. So this is certainly something that Health Canada's Substance Use and Addictions Program has invested a certain amount of money into trying to pilot these projects, and there's a lot of work that has come a long way in those interventions. The other thing that has come out that is very promising is the whole range of what has been referred to as safer supply. So, and there's a huge range to those kinds of interventions, and you know, we're still looking to see what's the best way to that can be delivered. But it's very promising because, as we know, and we've known for decades, really, a huge predictor of harm is the unpredictability of what people are putting in their bodies, and that's something that that can be controlled, and then we could have some levers on that, and so we could reduce a lot of harm if we're able to provide people some kind of a safer supply as an alternative to going to the illegal drug market and taking their chances to procuring what they need on the street. There's been a lot of harm among a group of people who use substances, and I don't want to diminish that, but there are some times when these kinds of instances can provide opportunities for kind of newer ways of newer policies, newer kinds of interventions, different ways of thinking, of breaking through. And I think those are two examples of that I wanted to highlight.
Thank you. Tracy.
I was going to say, Paula, too, as well, in talking about this area, virtual care, for many other things, has had a resurgence during this. There's been a huge uptake of it. We don't know yet how appropriate it was in all cases to use it, but it is an opportunity, as Matthew points out, about reshuffling the way we deliver care and thinking about care differently.
It's an excellent point, Tracy. I heard not too long ago about a program being done in the Vancouver downtown east side, where it was a virtual care, but it was a mobile clinic that actually came. And so it was virtual care, but they actually had, recognizing that not everyone can afford a telephone, or especially one with video, they actually had a van go to the downtown east side, and they were able to provide virtual care through a mobile clinic. So I think there are many wonderful examples across the country of programs and activities like that, but maybe not available in all parts of the country.
Well, and at CIHI, we're starting to do work on helping define virtual care and define some ways that we can measure patient experience with it. Particularly, we know during the pandemic that a lot of mental health care. So one of the things we're grappling with right now is we look at wait times for a new ongoing counseling indicator that we're doing. We have pre-pandemic data. It will be interesting to see what happens with that indicator during the pandemic, because we have had such an uptick in virtual care, and a lot of it for mental health has gone online. So are some of the challenges, are we going to see less waits for ongoing counseling, or are we going to see more waits? And it is linked to what might happen in the future for substance use as well.
It's an excellent point, Tracy. And I think looking at the data of in all of these areas throughout the pandemic will be insightful, because we know in terms of overall harms, wave 1 looked very different from wave 2, or what some are now calling wave 3. It'll be interesting to look at this data from that period, to look at it in 2021 and see if there are differences, to see if the length of the pandemic or changes in how the pandemic has affected the population comes out in terms of substance use harms. So a lot of opportunity for more work, for sure, not only from CIHI, but through partnership and collaboration with organizations like CCSA. Speaking of that, Matthew, hearing some of this information and your experience, what do you hope that CCSA can do with information like this?
Oh, this type of information is critically important to like everything that we do. We certainly will use this information and incorporate it into some of the economic cost modeling that we do, that we'll be able to assess, but also to, just pointing out, those gaps. It's more, I think that, it underscores the importance of getting better community level treatment indicators. It's a hard road to, and it'll be a hard path to follow, but those are critically important. The ongoing work at reducing stigma among people who use drugs. I think what we're seeing in many ways when we describe, and from Lisha's description of how care for substance use differs from care for other kinds of health conditions, really represents kind of a systemic stigma that is inherent in a system that against substance use disorders. We've come a long way with mental health. There's still a lot further to go, and substance use is even further behind that. So I think that being aware of that and moving that forward is something that CCSA has done a lot of work on in the stigma space, and will continue to. I'll leave it there because I could go on, but thank you.
Thank you. And Lisha, your work at CAPSA, you're much more focused at an individual level. But how do statistics or national numbers like these, how does that help you in your work? What can you do? What can you learn from this, or how can you use this information at CAPSA?
So we certainly are focused on reducing systemic stigma and supporting all pathways to substance use health. So we, of course, epidemiological data is always very important to situate and provide a certain degree of context to the importance of increasing substance use health and making a compassionate, equitable, and accessible substance use care system. One of the clear needs from CAPSA's perspective, and also in the position statement mentioned earlier, is that emergency departments are to provide treatment that is patient-centered, compassionate, and free from stigma and judgment. And at CAPSA, we provide substance use stigma reduction training and also different education services. So varying degrees of need of information. So we're able to modify our education knowledge products accordingly. And so we very much look forward to moving forward with that and really recognizing that hospital-based care is a pathway to increasing substance use health, and just supporting emergency departments in making sure that the care provided is compassionate and safe.
Thank you. I'll open this up to our panelists. We're just about closing in on time. I will remind members of the audience, if there are any questions that you'd like to pose to our panelists, feel free to type them in the chat. Maybe while we're waiting for that, any final comments or final thoughts from any of our panelists about the discussion we've had today, or where this could take us? Maybe Tracy, I'll ask you first.
So Paul, I would say that the mental health and substance use is an area that is an important area. Canadians have said it's important. So the suite of indicators that we're working on will help tell a story about these conditions, whether they're mental health conditions or substance use conditions or dual conditions that people have, and tell a story about access across the country and how we're doing in providing those services. We also are doing work at CIHI on patient-reported experience and outcome measures. So this is certainly in the mental health area. Some of the indicators that we are looking at doing in the future may very well have experience measures, which everybody's identified as important. Virtual care standards, as I said, are something we're working on, which impacts all care across Canada, and particularly the mental health and substance use care. And equity is another area. We heard this a little bit today about not discriminating and treating folks equal. So we are working on race-based standards and sex and gender standards, so that we can look at the data from that perspective and understand where some of our stigma happens in Canada.
Thank you. Matthew, anything to add in terms of final thoughts?
Nothing. Well, I think the one kind of one thing that I heard, I think it was a comedian, I heard him say one time, which I think has always stuck with me, and I say this frequently, is he said, like, I never had a drug problem, I had a reality problem. Drugs were my solution. And I think it sums up a lot of what we're talking about, and allows us to kind of exert that compassion muscle. Because the thing is when we really think about it, is oftentimes, people who use substances are doing so because it's rational for them to do so. They're oftentimes, a person might be in pain, they might be suffering, they may have an existing history of trauma, like Lisha was talking about. And so to think that to frame it like there is some kind of a problem of the will, or some kind of an issue like that is really, it's not helpful thinking, and it's inaccurate. And so I always like to remind myself of that. It's the reality that is the problem. And drugs are kind of a short-term and not very effective solution, but a solution nonetheless in the short term for people who use drugs. So I may just end with that.
Thank you, Matthew. We have had a question come in for Lisha. Lisha, audience member, asks, where can we access some of the training to combat stigma? And how would you suggest this training be beneficial for data analysts?
So you can go to capsa.ca. And there's a resource page, although some of those resources are somewhat dated. We, as an organization, can modify a training for your team if you would like. So feel free to email me or contact me. I can put my email in the chat box in a moment. It's very important for data analysts, of course, because I should ask first, if you're conducting community-based participatory action research, because in that case, you would likely have a number of perspectives and indicators that were formulated by recipients of substance use care. But in the case that you are not conducting that form of research, there is systemic level stigma that you may not be aware about. I certainly, even as a person with a substance use disorder, as a substance use disorder researcher, still used stigmatizing terms that I was unaware of. So there's no shame at all. We all have information that we don't know. You likely have read papers discussing the burden of substance use, right? A lot of the ways that we talk about people, even when we conduct epidemiological reports that are widely accepted as acceptable, can be quite stigmatizing. It's also very important, and it always in our substance use stigma reduction trainings, we talk about substance use disorder and the chronicity of substance use disorder symptoms, and therefore the need for substance use disorder symptom management throughout the life course, or an ongoing need for management of those symptoms, and of course ongoing need to access substance use care. So we really need to understand that an individual, given our current system, and even the term lived experience, one of the things that we're trying to encourage people to do is to only use the term living experience, because the term lived would presuppose that just because someone has successfully managed their substance use disorder symptoms, even for 5+ years, that there is now a responsibility for them to never have a reoccurrence in substance use disorder symptoms, which is unrealistic given the chronicity of the disorder. So I don't want to take too long, but we can talk more. I don't know if I've answered your question. Maybe you can let me know if I haven't. And I do see, so ultimately, I think it's important for data analysts, because you don't want to continue to perpetuate systemic stigma in what you write. And you also want to make sure that you're working towards research that involves people who actually receive substance use care, so it's a bit more meaningful to your target audiences. Matthew, did you want to answer the question on Indigenous health access, or?
I think he's suggesting.
Oh, please go ahead, Lisha. You've done a lot of work in that area, so
maybe I'll just, for the purposes of translation, I'll maybe read the question, Lisha, and then hand it back to you. An audience member observes that we haven't really touched on Indigenous health. I'm wondering if Lisha or Matthew can speak to equity and social deterrence of health and how this has affected Indigenous health perspective through the pandemic as it relates to substance use and access to services. Lisha.
Okay, so it's an excellent question. I am not representing an Indigenous organization, and I'm not Indigenous. So I'm going to encourage you to review a recording of a recent presentation that CAPSA and Thunderbird Partnership Foundation and CCSA participated in for the United Nations side event. And in that, Thunderbird Partnership Foundation and Maycat, who's a substance use care provider, a nurse practitioner, and treats opioid use disorder, spoke a lot about Indigenous determinants of health and some of the impacts of COVID. So I'll encourage you to look at that. But what I do want to share from that talk was that there has been use of traditional methods of healing. There has been a lot more land-based programming being delivered, particularly in Anishinaabe Nation, that was presented on, and the importance of culturally informed interventions. And it was also mentioned that people with substance use disorders are invited into the community, and there's a re-engagement with the community, and that there has been a lot of positive responses, Indigenous-led, self-determined responses to substance use and increasing substance use health in First Nation communities. But I appreciate your question, and I just don't want to misspeak. So I don't know if Tracy, maybe you have something to add to that.
Thanks, Lisha. I think that from a CIHI perspective, you said it well, that probably some of the best places to garner the information are from Indigenous Canadians, because they can speak more directly to their experience. At CIHI, we haven't specifically, we're building relationships to be able to report on many topics related to Indigenous health in a respectful way. So at the moment, we don't have any, we haven't done any breakdowns or looking at the substance use piece.
Thank you, Tracy. So we're just about out of time. Matthew, there was another question that came in. I think I'll actually refer it to, we'll refer the question to you, and perhaps you could provide a short written answer, but it's asking about the gap between knowledge and practice for effective treatment of substance use disorder, which I think is, it's a critically important question, and we would like your perspective, but I'm very mindful of time. So Lisha has put in her email address, and we will certainly share that question with Matthew and ask for his thoughts on that and share that back to the group. So in closing, I'd like to say thank you very much to our panelists, Lisha, Matthew, Tracy. Just wonderful discussion today, and we appreciate you taking the time today. And Lisha, we thank you for feeling comfortable enough to share your personal story with us. Very, very important to hear. Thank you to all the audience members who joined, and thank you to the CIHI team who is working diligently in the background. One final reminder before I let you go, we will have an evaluation form that we will soon share, and we hope that you fill that out, because we really do want to make these webinars meaningful, and your comments and feedback help us to do that. So thank you very much, everyone, and I wish you a healthy afternoon. Take care.